Welcome to Osteoporosis, a case study for advanced pharmacotherapeutics, Nursing 601. I am Chris Connor, and enjoy our journey. Osteoporosis is a loss of bone mass that occurs throughout the skeleton, predisposing patients to fractures, diagnosed through a DEXA, which we'll look at in the next couple slides. Risk factors, gender being female, advanced age, white or Asian ethnicity, thin, small frame body, positive family history, low calcium intake, early menopause, sedentary lifestyle, never having been pregnant, smoking, excessive alcohol and or caffeine intake, high protein and or phosphate intake, long-term use of certain medications like glucocorticoids, phenytoin, thyroid meds, and certain endocrine disorders, hyperthyroidism, and Cushing's. Our case study is Mary Lou. She's a 60-year-old female who recently had a DEXA scan, results of which were a T-score of negative 2.5 spine and negative 2.1 for her hips. Her concern, she had a friend who was on Boniva, and she states she broke her leg, and they told her it might have been caused by the Boniva. She's wondering if there's another kind of medication. She says she takes calcium tablets, but she hates them because they are so big. The DEXA scan we're going to look at, it's the gold standard for diagnosing osteoporosis. It's assessing bone mineral density by beaming two different x-rays of lower intensity toward the site of concern. Who should get tested? Women over the age of 65 or women under the age of 65 and men too that have clinical risk factors that set them up for risk of osteoporotic fracture. So our T-score, if it's -1 or above, it is normal bone density. If it's between -1 and -2.5, you have osteopenia, which is lacking bone. Higher risk for osteoporosis, and lower than -2.5 or -2.5 itself is diagnosis of osteoporosis. So our treatment options for osteoporosis, we're going to look at non-pharmacologic methods first. Prevention, of course, but once we get a little older, more risk factors building up. Exercise, we want to do low impact exercise, strength training, muscle and bone. Yoga, good for blood circulation, breathing. Expanding the chest cavity through the breathing, maintaining a healthy weight, appropriate weight. Diet and supplementation, reducing sodium intake if possible, reducing caffeine intake, and soda or any carbonated drink. Both carbonated drinks and caffeine can interrupt calcium absorption by the body. Appropriate calcium intake, which is 1,200 milligrams for women over 50. So that's our Mary Lou. And vitamin D intake. In adults, it's 600 international units daily, and up to 70 years old, and then it's a little more, 800. Glucosamine and chondroitin, we're talking about joint health, which, related to bones. Scientific evidence is not great for glucosamine chondroitin's efficacy, but some people swear by it, so it can't hurt. There's, low risk in taking it. Lifestyle, we want to quit smoking if possible. That slows down healing processes. Limiting alcohol intake and fall prevention. So for our pharmacological treatment, The bisphosphonates are the most commonly prescribed medication for osteoporosis. Method of action: they inhibit the resorption of bone by osteoclasts and may have an effect on the osteoblasts. Structurally similar to pyrophosphate, they have a high affinity for bone, and they probably remain in the bone after being absorbed there for many years. Absorption: it's poor intestinal absorption done by passive diffusion, but what does get to the bone remains there for years. Do not give within 60 minutes of meal times or with anything dairy containing, which will reduce the absorption further. Clearance: so whatever does not get absorbed by the bone, what's remaining is excreted in the urine. The half-life in circulation is 30 minutes to 2 hours. In bone, half-life is most likely several years due to the skeletal storage. Indications: we're looking primarily here at osteoporosis, so I left some of the other ones out. Administration for Boniva or bisphosphonates in general, by mouth or IV, which could be drip or bolus. Treating osteoporosis, again, continuing with the bisphosphonates, are examples: alendronate, which is Fosamax, that's a once weekly by mouth. Risendronate, which is Actonel, once a week. Ibandronate, which is Boniva, that's once monthly. And zoledronic acid, which is reclassed, that is in women but also used in men. It's an IV infusion given over 15 minutes. If you have osteoporosis, it's given every year, once a year. If it's preventing osteoporosis, it's every 2 years. So typically these things are prescribed for 3 to 5 years, but sometimes as long as 10. Other drug therapies: we have calcitonin, injected or inhaled. We have hormonal therapy. We have the SERMs, estrogen. We have thyroid, 40O, but it's very expensive, $750 a month. We have parathyroid-related protein, rank ligand inhibitors. We have tissue-selective estrogen complex, monoclonal antibodies. These are some of the new ones. Denosumab, which is Prolia. It's newer. It's subcutaneous. It's twice a year, and it's not associated with osteonecrosis, which is the picture on the top right. Particularly in the jaw, they see that osteonecrosis. So focusing now on Boniva, ibandronate, which is Boniva, it's an anti-osteoporotic. It is a bisphosphonate, as we talked about. Our forms: we can have the prefilled syringe for injection or the tablets, which they say do not crush. Indication here is for women to treat or prevent postmenopausal osteoporosis. So that's our case, Mary Lou. Administration PO, we said, take the tablet 1 hour before food or drink, and don't lie down for at least an hour. We want that maximal intestinal absorption. An IV, it's a bolus given over 15 to 30 seconds, but not to be given with anything calcium containing. Action: as we said, it inhibits bone breakdown and removal by those osteoclasts. I want to avoid aspirin and NSAIDs because of GI upset. Any products containing aluminum, calcium, magnesium, and iron, they're going to reduce the absorption further. So the most serious side effects we look at with Boniva are pharyngitis and dysphagia, hypocalcemia, the myalgia and arthralgia, so muscle and joint and even pain, osteonecrosis, like we talked about. It's breakdown usually seen in the jaw, and atypical or unusual thigh fractures. Contraindications may cause that atypical thigh fracture. That's an alert. We want to avoid use in severe renal impairment, so if creatinine clearance is less than 30. We want to caution in patients with a history of GI disorder, And we want to look for overdose signs and symptoms such as hypocalcemia, hypophosphatemia, and hypomagnesemia. Nursing considerations: monitor for that hypocalcemia, check calcium levels before starting therapy, maintain in your patient adequate vitamin D and calcium intake, watching for signs and symptoms of dysphagia, heartburn, esophagitis, and monitor for an osteonecrosis and the joint, muscle, and bone pain. We want to teach the patient to take this oral dose at the same day each month with just a big amount of water and nothing else. We want to keep them upright for an hour post taking the pill for that maximal absorption. We want to tell them not to chew or suck on the tablet because that can, lead to that esophagitis. And have them stop and report to us if they have dysphagia, esophagitis, retrosternal pain, or heartburn, and to help monitor for osteonecrosis, regular periodontal exams. So looking back at our case with Mary Lou, her results again, negative 2.5 T-score for her spine. That's telling us she does have osteoporosis in the spine. And a negative 2.1 in the hips. She is osteopenic in the hips, but she is at risk for osteoporosis. High risk there. So she is a candidate for an anti-osteoporotic medication such as Boniva. If she's not, if she's concerned with the Boniva, we're going to talk about, risks and benefits of it, if the benefits outweigh the risks. Goal of therapy, ultimately, we're trying to prevent fractures, reduce pain. We're trying to maintain that bone mineral density as much as possible and maintain her overall quality of life, prevent falls. Her original concern regarding her friend's hip fracture, that is an adverse reaction. It is a valid concern. Calcium levels should be monitoring, risk for that hypocalcemia. And, she's going to be advised on what to be aware of and to report it to us immediately. Regarding her calcium tablets being too large, hard to swallow, she does have plenty of other options for that, and we'll let her know about that. Calcium chews, gummy chews, syrup, liquid tabs. There's different options for her. So certainly we're going to review the non-pharmacologic strategies for her overall bone health to maintain that bone mass and bone mineral density for as long as possible. And we're going to meet her where she's at, informing her of her risks and benefits of the different therapy options. And we're going to come together. We're going to mutually agree on a treatment plan and go from there. Last but not least, our references. There's plenty of information on osteoporosis and treatment options out there. I want to thank you for listening to this presentation.